So also medication, exposure to amphetamine, phenytoin, diuretic, and vaginal infection treatment, the vaginal creams. Breastfeeding and folic acid has been found to be protective in this condition. So the causes, it is mainly sporadic, but there's a small percentage of this disease which is familial, 1 to 2%. So looking at the causes, so you can look at some of the oncogenes that are associated with the disease. So these oncogenes, there's one when they are turned on, which is amplification, NMIC amplification, which are associated with your high risk, poor prognosis disease. And you also get the mutation of your tumor suppressor gene when you get the deletion of those disease, which is associated with the FOX2B and chromosome 1 and 11, those that are seen in your familial group. So associated syndrome with this disease. So as you can see, most of these conditions, they're associated also with the nervous, with the peripheral nervous system. So this is like Hirschsprung disease, which is the aganglionosis of your intestine, your central hypoventilation syndrome, and your recurrent heart disease, your Horner's syndrome as well, which is mostly as a complication of basically the compression of the tumor that's growing in the neck that will give you this Horner's syndrome. Clinical features. So clinical features are related to the rapid local growth of the disease. We look at the clinical features that are related to the metastasis of the disease and those that are related to hormones. Clinical features that are related to local growth. So you may be able to appreciate a solid abdominal mass. The patient may present with the abdominal distension. It can be abdominal pain. Also, the distension could be also from the metastasis to the liver already, or it can be related to the metastasis, which it can be to bone, and this disease like to go to the bone, the liver, and as well as the lymph nodes. So in the bone mets, you get patient presenting with raccoon eyes, which basically the mets, they cause some features in the base of the skull with basically ecchymosis around the eyes. And then you also get skin lesions, which are described as purplish and painless skin lesion as well. Related to hormones is the release of the catecholamines, which would result in the loss of weight, hypertension, sweaty, and flushing as well. So these bluish nodules on the skin. So the beds, they look like this. They are painless. They feel like they're just under the skin. And here you've got a baby also who's got abdominal distension. And on the other side, you can see also the skin mats that are throughout the body. And the diagnosis of neuroblastoma, it can be made based on histology. It can be made based on urine, where you look for your catecholamine. You can measure VMA and MHA as well. Then you can do your laboratory chemistry, where you look for LDH, you look for ferritin as well, and your neuron-specific analysis. Even things like basic full blood count can give you an indication. When the patient has had a bone marrow mets, they can come in with anemia as well that you'll be able to pick up from your full blood count. Imaging is part of the investigations. So you can be able to appreciate a mass on your plain chest X-ray or CT scan, MRI, even an ultrasound. One of the basics scans that you can do. And there's also an MIG scan, which basically looks at the mets that you aren't able to pick them up on the CT scan. You can also do a bone marrow biopsy. This is the representation of the MIB scan, which shows areas of high uptake, the darkened areas. Those are the areas which show the presence of metastatic disease. This is an MRI of the neck, you can see on your left, which shows the tumor. It's a large, solid the tumor that's invading the neck. And on the left side, you can see the thoracic tumor there. Okay. And then, so now looking at the staging of this disease. So it is staged from stage 1 to stage 4S, where basically you have stage 1 here, which is your local tumor, which can be completely excised with negative lymph nodes of the same size. That is your stage 1, and then you have your stage 2A, which is also basically, it's a localized tumor with incomplete resection, but with negative lymph nodes of the same side. And then 2B is a tumor which is completely excised, but with positive ipsilateral lymph nodes. And then moving to stage 3. So stage 3, it's basically a tumor that is in the midline. You can either have you can have 3 possibilities in this case. It's an irresectable tumor which is crossing the midline. And the other option, you have a local tumor which is completely excisable, but with positive lymph nodes of the opposite side. Or you can have a tumor, a localized tumor, which have a bilateral positive lymph nodes. And then your stage 4, it's basically your metastatic disease. So you have your distant mets on the liver, it could be on the liver, on the bone, or the skin. Then you have a special group, which is a group which is 4S. This one is limited to the infant, and they present with a localized tumor, which already present with mets either to the skin, the bone, to the skin and the bone as well. But this one, the stage 4S, has a good prognosis, because it can actually regress if it's not showing any symptoms that would need a treatment at that time. So, yeah. Okay, so then there is this is the new international neuroblastoma risk staging system, which basically looks at the local, which looks at locally and the metastatic process of the disease. So It basically looks at whether does it involve your vital structures. It also look at whether it has your image defining risk factors. That's your L1. Your L2 is your local regional tumors with the presenting of one or more of the image defining risk factors. And then M is for distant metastatic disease. This exclude MS, which is the one that we refer to as for S as well, which is limited to the infant with the spread to the skin, liver, and the bone marrow. So risk grouping, this is a children oncology risk grouping. So you get your low risk, your intermediate risk, and your high risk, high risk disease. So on your low risk disease, this is your stage 1 and stage 2A with a favorable histology. Intermediate risk is stage 2B and stage 3 with NIC amplification, and high risk is case of multiple NIC amplification and stage 4 diseases. This is a more detailed page of looking at the disease, and it's basically it's what we have gone through, but this looks at now you have your histology, you look at your myosin, look at the probability of the disease, and it gives you your risk stratification here based on all your biological, histological, and your genetic features. So management of the disease, it is based on staging, low risk, that can be surgically resected without additional adjuvant chemotherapy. Intermediate risk, these ones, they can be resected, these tumors that can be resected with chemo, and then they will need adjuvant chemo with or without radiotherapy. High risk tumors, those they need chemotherapy to downstage. It could be chemotherapy and radiation even before the operation to downstage the disease, and then they can be tried for operation, or if it's non-resectable, then they will only receive chemotherapy and radiation. So the mainstay of treatment is chemotherapy. There is also an option of bone marrow transplant, radiation, and you have your radiotherapy, your surgical resection, and your new modalities now, your immunotherapies. So your surgical management, you have laparoscopic options, your open surgical options. This depends on the site of the tumor and the size of the tumor, as well as the experience of the surgeon. You also, surgical timing, it depends on the stage of the disease, and also it depends on the available skills at the time as well, because this can be a very difficult tumors to operate on, especially around the vessels, as they tend to grow around very close to the vessels. So in conclusion, neuroblastomas, they are the tumors of the neural cell origin. They are very common. Adequate biopsy is required for diagnosis. There are multimodalities for diagnosis. poor outcome for those that are present at the late stage. Neuroblastomas have a favorable outcome if they are discovered at the infancy. And treatment is also based on stages. And so our references. Thank you. Let me see if I can go back.
Okay, we have to find a way
yeah,
to cancel your screen sharing.
Sorry.
Okay,
Wait.
try that. Okay, I think I can do it from my side, Zwandile.
Okay.
Okay. Okay. Zwandile, that was a good basic talk. I'll invite Yashoda to first comment and give her advice, opinion, and then one after the other, then I'll ask people to ask questions or give comments. Yashoda?
Okay, Prof. Can you hear me?
Yes, yes.
Yes, can
Okay.
hear.
Okay. Okay, thanks, Zwandile. Yeah, it was quite basic. I missed the beginning. Unfortunately, I was having problems connecting. But you said it was very common. How many have you seen?
Not many.
Yeah. So where did you see that it was very common?
So actually, I think the statement, I will revise it. I wouldn't say very common. So it's a common childhood tumor.
Okay,
And
in the developed world, which is where all the data is coming from.
Yes.
Right?
So it is actually, they said that it's more common than what we see, because some of the tumors, they actually regress before they even present or before we even see the symptoms. They did say that in the percentages are quite high on the infants that they did postmortems on who had other causes of death, and even higher on the infants that have cardiac anomalies as well. But with that information, this is when they decided that, because I think countries like Japan, they had done something like surveillance, like screening.
Yes,
and then
good, yeah.
They discovered that screening basically doesn't change the mortality and the morbidity of the disease itself. So they also did away with the screening, because they picked up a lot of tumors, but most of them regressed.
Yes, for that reason. So they regress with time because they mature with time. Yes. So yes, they did do screening in Japan in neonates, and they found that there was a high incidence, but they regressed with time. And that brings into the forefront my other point was that this is a spectrum of disease, right? So yes. You talking about the neuroblastoma, the one that's the immature one, the one that we're more concerned about, right?
Yes.
So that's uncommon, right?
Okay.
Okay, so I just wanted to clear that out.
To clear that, yes. Okay. Yeah.
What's the most common solid tumor that you see?
Sorry, I can't hear you now.
I said, what's the most common solid tumor that you see?
Those are nephroblastomas.
Yes.
That I see.
Yeah. Yes. So what you want to do is you want to differentiate between them, right? When you see a patient. So how do you differentiate between them?
Okay.
So you see a child with an abdominal mass, and
yes.
it could be a neuroblastoma, it could be a nephroblastoma. What differentiates them for you?
Okay. Well, the nephroblastomas don't usually crosses the midline, and also the type of the mass that they present with, if it's an abdominal mass, some nephroblastomas you can actually they move with respiration, inspiration, and expiration, but the neuroblastomas they don't give you that that sign. Also, with some of the clinical presentation, as I've mentioned that the neuroblastomas, they might even present with already with metastatic disease. They progress.
Yeah.
The progression is quite faster than that of the nephroblastomas.
Okay. So how do they feel? Like when you feel the child's abdomen, how does it feel? So I'm sure I've told you this before, but if I haven't, the nephroblastomas are smooth and they feel like a watermelon. And the neuroblastomas are irregular. So they feel like a sack of potatoes, right? That's one of the first things that you can notice about them. But if it's coming from the adrenal, then it's going to look just like a nephro, right?
Yes.
Yeah. So, and yeah, but you're right about the metastases and things. Then on the X-ray, you said you would do an X-ray. What can you see on the X-ray?
So on the X-ray, if you have a thoracic mass on the chest X-ray, you can see maybe a widening of the mediastinum.
Sure.
Yes, and you can also see, you might be able to see also what might look like an apical, sort of like a lung apical mass in when you have the tumor that is from the neck that's going into your thoracic inlet.
Okay, so if you have an abdominal mass and you do an X-ray, what can you see?
You can see calcifications in these tumors. Yeah, you are
that's
able
what I was
to,
looking for, right? So that's going to differentiate it from a nephro as well, because you can see calcification. Okay, so you didn't mention that, so I was just checking if you.
It is important. It is important to mention plain abdominal X-ray because some of them will probably come with a plain abdominal X-ray.
Yes. So. Yeah, but you did mention X-ray, but you didn't say why.
Yeah.
Because, right, but you know it. That's fine. Then another presentation I would like you to cover was paraplegia. Have you heard of children presenting with paraplegia with neuroblastomas?
Yes, I did find that they can present with the neurological symptoms, which are associated. They can also present with your bladder continent issues as well, associated with that if they have a pelvic extension of the disease.
Yeah, so they can invade the spinal cord, the spinal column, right? And they can even invade the vertebral bodies and cause compression. So they can present with spinal abnormalities. So that's very important because during surgery, you're going to have to address that. And do you know how you address that? Because it's causing compression. So how do you decompress? Have you come across this? No.
No. With some of the neurological oncological emergencies that will give you paraplegia or neurological sign, I think some of the patients, they will need an urgent radiation.
Okay, it is an option, but if surgery can be done safely, it's quicker and it is an emergency, to decompress the spinal cord, and you do a laminotomy for that, or laminectomy. So you open the lamina to just decompress. and then you remove the tumor. So you excise the tumor. So it's an important presentation to know about, because they can confuse you when they come in with sudden paraplegia and you have to do something about it. So it is important. Then what is an MIBG scan?
It's a nuclear medicine scan.
Yes.
So
do you know what it stands for?
I saw the name. I think the name of the agent that they use is benzo. It's sorry.
Okay, it's meta-iodo benzyl guanidine, right?
Yes.
Now it's important to know because it resembles the molecule of noradrenaline.
Oh.
Right? So that's why it lights up for neuroblastoma. Okay? Because it's taken up by those tissues that are making noradrenaline, but it's not excreted, so it's retained, and that's why it lights up. Okay. So, but it's important to know that, because you don't use it for any other tumors.
And it is.
So you should have wondered why. Why do we use an MIBG in neuroblastoma? And you know, it's just good to know.
Yes. All right.
Okay, and then what else did I want to tell you? Okay, so as a surgeon, the most important staging that you talked about is the image-defining risk factors, right? Because that is telling you about encasement of the vessels and vital structures, like you said. So that risk grouping is the most important to you as a surgeon, for you to make a decision whether you can operate or not in a neuroblastoma. Did you come across what the survival is in a stage 4?
Yes, I did not hear much about the prognosis and the survival. Huh?
Sorry, I didn't get that, the last part.
Yes, I did not also hear about the prognosis and the survival.
The last part,
yeah. Okay. Well.
Yes. Okay. The prognosis. So,
no, it's okay, Zwandile. That's something to remember and to cover. Yashoda?
Sorry, on the risk, can I just?
No, it's fine.
So the risk grouping it's important for that. It's important for prognostication as well. Why? Because the stage 4 has an 11% survival, right?
Yes.
So when they are stage 4, we don't normally operate on them.
Right.
But I wouldn't say never, because there are some tumors that will respond and the metastases regress. This is very rare, but it can happen, and we have operated on one that was a stage 4. So I won't say we never operate on them, but it has a very, very low survival generally.
Okay. Yashoda, can I ask other consultants to comment now?
Yeah, sure.
Kulileko, you can comment or make any advice.
Oh, sorry, I missed the last part because I was having a cough. But it's quite basic, the presentation, which basically covers the initial part of what he needs to know.
Correct.
When it comes to the disease itself.
Yeah.
So Yashoda has gone through some of the stuff that I wanted to just clarify with him as well when it comes to basically the clinical assessment of these kids, because these are the ones that really come in quite sick.
Yes.
Although because of the late presentation and also because of the aggressiveness of the tumor.
Right.
and you also mentioned about just the typical X-ray that they'll have calcification. When it comes to diagnosis, you can, besides, you need to have a histology, which is where the rosette, where histology comes in, where you have your blue round cells, and that you can also do on just a bone marrow biopsy. And also, but you need to have positive catecholamines in the urine, because with those two, then you can diagnose that this is a neuroblastoma without doing anything further. Although you'll still go through the other things of getting your images so that you can state the child. And then it has been changed now, because at the stage 4S, we used to say it's the prognosis is good for a child who's less than a year. So it's been upgraded to less than 18 months. So that's the new thing that you just need to add onto the slides. So it's less than 18 months now, not less than 12 months. But then everything else, I think it's fine. I'm not sure what you talked about in the last 10 minutes, because I was on a call.
No, but I fully agree with you, Kuleleko and Yashoda. Zwandile, this is very basic presentation to start with, but there are many details which you and all the other registrars need to read to understand and subsequently be able to answer. So, Selo, are you able to comment?
Sorry, just one more thing.
Yes, sure.
And then we're not. I think he left out surgical management on purpose, because he didn't cover it. So I don't think I should speak about it.
Sure.
Okay.
Yeah. Selo, are you able to talk?
So I said, can you hear me, Prof?
Yes, we can hear you.
Yeah, we can hear you.
Yeah, shame. I'll invest in fiber soon. My one comment, or it's neuroblastoma is quite challenging. I think concept of, but the only thing I wanted to ask is only
Yes.
about surveillance, that there's a come across whether we do it or don't do it. And the other question is linked to that. Why specifically is it a favorable thing to have neuroblastoma when you are 1 year or 18 months?
Selo, your voice quality is not good. Sorry,
Yeah, it sounds like an alien.
there is a lot of echo.
3 years, 5 years. Does he know?
Selo,
I think he's just talking about 4S.
Yeah, he's talking about 4S, but I think you've covered it, because he mentioned this.
we mentioned about surveillance.
I missed part of Selo's comment.
Yeah, no, he was asking you have you come across surveillance, which you spoke about with Yashoda when you mentioned the Japan studies.
Yes.
And then he also mentioned, why is it better to have the tumor quite early when we're speaking about the 4S? So that you can answer, why is it better to have neuroblastoma quite early, less than 12 months to less than 18 months, as compared to the other older children more than 3 years?
Yes. So in younger children, it tend to regress, and it tend to be less aggressive. It's more aggressive in children mostly over the age of 5.
Okay.
Let me. Can you hear me?
Yes, we can hear you, Selo.
Yes, we can hear you now.
Oh, yes. Sorry about the connection stream. My thing is.
We are losing you. We are losing you.
It stems on those cells in the
Selo, your voice quality is poor, so maybe you can type your comment.
adrenal glands. That's why when you're looking at
Selo, sorry, we can't hear you. Dr. Coppola and Prof. Delgado are with us. So I'm just going to ask Dr. Coppola first. I know he could only join a bit late, but Funeko, if you are able to comment. Funeko?
Yes, Practitioners.
Yes, I know you could only join a bit later, but is there anything you would like to
Yes.
comment or say about whatever you could attend?
No, Prof, it's very little what I've attended. I'll just listen
Okay.
to the comments. Thank
Okay,
you.
no problem. Thank you. And I think Prof. Delgado also could join quite late. I'm just going to say hello to him. Arturo, hello. Thank you for joining. Neha, you can make comments or ask questions.
Sure. So, Prof, the presentation was good. I just want to answer what Stella was trying to. Sorry, can you all hear me?
Yes, we can hear you. Go ahead.
Okay.
Yes.
So the question he was asked. So my understanding is that in a child who's less than 18 months, the reason why their response to surgery and chemotherapy is better because the cells are more immature, more closer to fetal origin. So the response to chemotherapy is better. That's what I understand by it. And as they progress in their age, the tumor obviously changes its histology and it becomes more aggressive, more difficult to treat chemotherapy-wise. Is that what the understanding is?
I'll ask Kululeko to comment first, and then I'll ask Yashoda to comment. Yes.
All
Okay.
right. So yes, the reason for the 4S or the younger kids to respond better is basically that their response to chemotherapy is better as compared to the older children because of the closeness of, as you said, of the cells to the fetal cells, and also they haven't. They're still immature and haven't really differentiated to the more aggressive type of, or changed into the more aggressive type of the cells. So that's why, because they respond better to
Yes, I understood. Yeah.
more to chemo than to surgery, because the 4S usually they present with, if I can say it, the more sort of later, sort of not late presentation, but the way they present is sort of like they look more aggressive because they've already got metastatic to the liver. They've got big livers. They look quite ill. But when you initiate them on chemotherapy or neoadjuvant therapy, then they respond and become better.
Sure.
As compared to the older child who won't respond as well as the other ones.
So I have another question.
Sorry, Neha, let Yashoda comment on your first question.
Sure, Prof.
Yes, so I missed a whole lot of that because it was breaking up for me. I don't know if it was breaking up for everyone else. But I think I got what Neha was trying to ask, and I think Nkuleko did answer. But the other thing to remember is that, yes, they do present early on in infancy. And then what happens is that they mature with time. So the ones that don't mature with time present, with late the aggressive disease. So you won't see the ones that have matured. You understand? So that's why they look like aggressive tumors when you see them in older children, and they have a poor prognosis because they're usually stage 4. They're usually aggressive tumors which were going to get to stage 4 anyway. So you see, those are the ones you are seeing in the older children. The ones that are maturing, you don't see them. You might actually see, I think we did take out a ganglioneuroma recently, which is the mature type of this tumor.
Which is mature type, yes.
Right. So the ones biologically, and usually they're the ones with the chromosomal abnormalities and the Mibg amplification, those are the ones that are aggressive. That's why it's important to group and stage them according to histology, according to those factors, because that'll tell you how aggressive this tumor is going to be.
Okay, Neha, your next
question. So the biology is very important. Yeah.
I missed one thing. So my understanding for diagnosis, you need 3 things. You need histology, you need your urine catecholamines, and you need a bone marrow as well. Is that correct? So your histology will tell you about the type of tumor. It will also give you a bit of the biology. So the Mibg amplification, it will give you all the factors he mentioned, the DNA plody, the TRK, the stromal rich, stromal poor, if it's nodular, not nodular, what type of neuroblastoma is it, and the Mibg, yeah.
Okay,
Mibg.
So you can answer.
And then, and then it's your urine catecholamines that you also have to collect, and you also have to look at your bone marrow as well. Is that correct?
Yes, so that's diagnosis and that's staging. So you diagnose it with those. He went through all of those quite well. I think the investigations that you would do. So those are all the things you'd have to do, and you'd have to stage it. But because, like I said, the staging matters a lot to you, and how you're going to risk, weigh the risk of surgery and chemotherapy and radiotherapy, etc. So this pre-op staging is very important as well. So the imaging and how far it's already spread is important for you to now make a plan for your management pre-op. Does that answer your question, Neha?
Yes, thank you, Yashoda.
Okay.
Anybody else want to make a comment, ask a question? Just raise your hand. I might have to unmute your mic.
Prof.
Yes.
Yeah. Just what they were talking about. So, Neha, for diagnosis, you just need 2 things. You need a bone marrow biopsy, and you need a positive catecholamines. But you still need the other stuff for staging and planning of your treatment. So just for diagnosis, you just need 2 things: the bone marrow aspirate and the catecholamines in the urine.
Okay.
Yeah.
Okay.
Okay, I understand that. Yeah.
Yeah.
Kirsty?
There's a question from Kirsty.
Jandile can answer that question.
Okay.
Jandile, could you read the question? So Kirsty is asking, in the baby where it resolves, does there remain a nodule or scarring, or is it completely gone? Jandile? Jandile, can you hear us? I think Jandile is probably is losing connection. Kirsty, to answer your question, it depends at what stage you look at that. So some tumors which may completely differentiate, they may become a smaller nodule. Some of them do disappear. So to answer your question is, it depends on at what stage of that tumor you do the imaging, or you have gone in and seen the tumor. Does it answer your question, Kirsty?
Yes, Prof. So that's why screening isn't so useful.
No.
Because you don't know at what stage you're catching the mass.
No. So it was done in Canada, it was done in Japan. They were thrilled because they diagnosed hundreds of neuroblastomas, but many of them later on regressed in almost in infancy. So it was not found to be useful. Okay, I'm just going to summarize. I hope Jandile can hear. Okay. Jandile, can you hear us? Jandile? Sorry, Jandile?
Yes.
Okay, can you hear us?
Yes, I can hear you now, Prof.
Okay.
I'm just
Then you lost
my
connection. I'm just going to summarize now. So Jandile, it was good presentation as a very basic presentation, but I don't know whether you read African textbook of pediatric surgery. If you didn't read African textbook of pediatric surgery, you need to read that. And a general comment is, this is a spectrum of disorders. This tumor arises at different sites. It can arise in the neck, in the chest, in the abdomen, retroperitoneum, in the adrenal, in the pelvis. It can give various symptoms because of pure size with compression. It can give symptoms because of hormones, and there are some symptoms which are not due to either pressure or hormones, but they are just because of some things it secretes. Also, it has got very different or varied biological factors. Emic, oncogen, then TRK, ploidy, diploidy. So there are various factors we need to consider to understand this tumor, to understand the spread, stage it, plan the treatment, plan surgery, and also prognosticate. So I think next time in a year or so, Jandile, we will expect a more sort of advanced presentation from you. Okay. I think if everybody.
All right, Prof.
Okay, I'm going to then close the meeting. I think it went well, and I have recorded most of the meeting. Thank you very much, everybody, including Prof. Delgado, Dr. Popolo, Crystal, and I don't know who is Yamkela. She's probably from Umtata. So
Tata, yes.
yeah, we will.
Thanks, Prof.
Yeah, we will have a meeting next time. Okay, thank you.
Sure, bye.
Bye.
Thank you.
Bye.
Bye.